Welcome back to Reimagine 2020. I'm Yonah Hochhauser, and today I'm very glad and privileged to be hosting this health-focused panel with three really experts in their fields, for those who know. And I'll go introduce you guys one by one. First up, Dr. Alex Cahana, founding member of the BTBlock Health Group. Alex, pleasure to speak to you again.
Good to see you.
All right, and next up, we got Dr. Samantha Nazareth, Chief Medical Officer at metaMe. Samantha, thanks for joining us.
Thank you for having me.
All right, and lastly, we have Claire Matuka, Data Scientist at Afia Record. Claire, thanks so much for being here.
Thank you, pleasure to be here.
All right, so we have a lot to cover, so let's jump right into it. Alex, last time I spoke to you, we focused mostly on blockchain's role in revolutionizing healthcare, and especially its role now that healthcare has seemingly become the forefront of people's worries and minds due to the COVID-19 crisis and pandemic that's affecting everywhere in the world. We're a couple months past that now. How do you see COVID-19 progressing at this point, and the various solutions and responses that have been thought of in response?
Well, I'm calling from New York, so obviously I have the New York and the US perspective of this. And for those who are following the news, actually the situation in New York is getting better because we are following the science and we are following the recommendations of the World Health Organization and the Centers for Disease Control. But in the US, it's a mixed bag, and we are entering a third wave. And the reality is that our reactions or our responses to COVID-19 are really based on the trust, or if you want, the mistrust that individuals have to the information that is given to them. So we actually are looking at the same data, but the actionable information is different. And one is saying, oh, I should wear masks and social distance. And the other says, no, I will take off my mask and actually be very close. And so this just re-emphasizes the importance of distributed ledger technology, as I said last time, to be the software of the social problem of trust, or in this case, mistrust. And we'll talk about the features of how the DLT, or distributed ledger technology, does that. I want to contrary that to what is going on in Africa, and I'm sure that Claire will talk about that as well, but following their numbers, for example, and again, this is a whole continent, so you can't generalize everything, but at least what pertains to Kenya or Tanzania or the East African states, actually the situation is way better. And I'm sure that among the audience that is not part of the African scene, they're saying, oh, well, sure, it's because they're not reporting and because they're fudging the numbers and they're not testing. And I would argue that, no, that's actually what we're doing. We're fudging the numbers, we're not testing. And the reason of why things are going so well in Africa in front of this, if you want global biological warfare, is because they are following the science. They have an extreme experience in outbreaks. And so be it Ebola or dengue or any other type of infectious outbreak, they understand the science behind it and the data and the data technology boom that is happening now in the African continent. And also, as you can tell by the panel, they are younger. So we have also half of the population that's under 30. So I think that if anything, COVID has continued to force us to confront the limitations of our system and emphasize the need to migrate and transfer into the blockchain AI world.
Well, I think you touched upon such an important point, because this should really be a scientific problem. You know, we have X amount of sick people, this is the cause of this, and this is the solution. And it seems like somehow this pandemic has become politicized across the board, when I don't know how it became political. I don't know where there's room for politics in the issue. So Samantha, this question is to you, where it's seemingly, there's, like Alex said, there's distrust here. And people say, wear a mask. No, I don't want to wear a mask. It doesn't do this. And everyone seemingly, it seems like we're not playing with the same facts here. So how can the technology that is available to us today help fix this problem of a lack of people trusting the facts that are being said.
Mm-hmm. And I'll put this also in context. I'm a practicing gastroenterologist in New York City. So there's definitely been issues amongst my peers as well, locally and globally, to share information. But this also becomes an issue with the citizens of what information should be shared and what should be trusted. So if you look at, and I would say, let's look at artificial intelligence and blockchain, because the combination of the two can really help with this matter. Just to give you some perspective, even before COVID, the amount of medical knowledge that's basically out there is doubling every couple of months. That was quoted back in 2011, slated for 2020. Now that we're in 2020, I don't think those authors predicted what would happen, what's happening now. I'm sure that medical knowledge is doubling even faster. So you have all of this information that needs to be collated, analyzed, and housed somewhere. And this is, again, globally, global knowledge, and especially given the fact that different countries were experiencing COVID at different times of the year. And anecdotally, physicians always talk about things that are not in the news, treatments that have worked within our own circles, but that information needs to be shared with others, other physicians, other systems, in a safe space, in a space that you can be anonymized. You know, perhaps you don't want to reveal that you are, you know, my name and attached to this employer for certain repercussions that might happen. So then, you know, the AI helps with the data layer of collating all of that data, and the blockchain really helps with that ability to speak to peers without anybody in the middle getting, you know, entangled in that or even censoring that conversation. And then also that extra layer, which would be helpful, is that anonymity, right? Because if you've seen in the news, doctors that have spoken out about bad practices that were happening, the mask issue, the lack of PPE, all of those things, they were getting reprimanded basically by their employers. So you need a space where you can speak up, right, in a peer-to-peer fashion, not be censored, and have honest conversations that can push the medical knowledge forward, because then it becomes an everybody issue, right? Like we have to be able to speak about what's happening in our own local areas, but to really push forward the treatment that's going to help everybody globally.
For sure. I mean, and you and Alex are both right now in New York. And if we're talking about globally, we're digitally sitting next to, you know, our colleague here, Claire, who's, you're sitting in Africa right now, Kenya, I believe. Claire, so does that hold true? I mean, this is a global pandemic. This is facing, this is people worldwide are facing this wherever they sit. And how is the situation on the ground there? Alex mentioned earlier that it seems like Africa is actually, or parts of Africa, are handling it better than others. What is unique about the situation on the ground there that has allowed them to get ahead of this?
Thank you so much, Yonah. So actually, I think that it would be interesting, first of all, for us to have actual data to prove whatever is happening here in Kenya and Africa. There's so much hearsay as to people are saying, oh no, the genes are better. Some people are saying now the story that you've just given about us handling it better. Some people are saying, like, there's so much around it, and it would be awesome to have AI, data analysis, all that fused together for us to actually know what's happening on the ground. So recently I had the chance to actually analyze a bit of the COVID data, and the one interesting thing about what's happening here is that every single facility that's testing for COVID or carrying out COVID tests is somehow using a different method to report their results. So we're finding like so many results are coming in, but 10 results from this place look different, 10 results from this place look different. One person is testing for one different thing, the other person is testing for something else. So you might find yourself negative in one area and positive in another because they're all testing for different things. But I think the interesting thing is that at the end of it all, we still are reporting lower cases. And I think it's also because, as you've said, we are more experienced with outbreaks and all these things. And so, yeah.
For sure. I mean, and I think that's a big challenge. I mean, for data scientists everywhere is knowing, how good is my data coming in? You're trying to analyze data, but like you mentioned, there are so many different ways of testing. I'm no medical expert, so whichever one of you is best here, how do we deal with it? If we're trying to use data to help fight this pandemic, it does seem like a certain percentage of tests are false negatives. How as a data scientist, how do you deal and filter out false negatives and false positives?
Okay, so for most of the time, the best option is actually to figure out how many false negatives do you think there are. And then from there, you can be able to either decide whether to eliminate them or to figure out something else, how you can replace those values and make them actually valid. Because in data science, it's not actually very good to get rid of data because it's very, very important. And I think something else that maybe globally, not only like in Africa or Kenya or in New York and the States you can do, is we need to have policies in check as to how we're measuring COVID results, how we're reporting all these results. And this way, if, for example, Claire, me as a data scientist here, I join forces with data scientists in the States, we all have this data and together we can globally report the COVID results.
Mm-hmm. Alex, I saw you want to say something.
Yeah, I think that we just to crystallize for the audience that's listening, I think that we mentioned the elements where DLT and AI serve in transforming raw data into actionable information, and from there into policies, knowledge and policies, is that the provenance of the data has to be known. The transparency and integrity of the data. In AI or in machine learning, labeling is the most labor-intensive part of the work there. So creating a decentralized a mechanism that would incentivize people to do it correctly, and I think that incentive for exchange is the most important thing, because to remind the audience the power of decentralization, it is that it is attack resistant, it is collusion resistant, and it is censorship resistant. And these are all the necessary elements to deal with the mistrust of what we have right now. And for example, if I think of Afia Record, they've developed a very elegant way to track individuals without infringing on their privacy, by using geofencing and by using the semantics of their symptoms. So instead of saying, oh, this is Alex Cahana who lives here so-and-so, and because he said something nice, we want to follow and track him. This is like, here's gentleman X who's coughing, and now I'm driving into a neighborhood and suddenly I see a lot of red dot coughers, and maybe I'll make a U-turn and get out of there. Now, of course, once you're positive, then tracing, tracking, and isolation, we go into science, and then there are public health considerations of where your privacy lies when you are infected. But until that threshold, it is vital that all these instruments, very powerful instruments that have been developed, are not used as a biometric surveillance state to actually be abused for other reasons other than control of an outbreak.
Mm-hmm. And Samantha, to you're practicing, you're a doctor right now, and what is the feeling amongst your colleagues about the ever growing presence of technology in the medical field? Not talking about research, but talking about actually on the ground treating of patients. Do like the old schoolers? Do they kind of brush it off and say, I don't trust that. I have a feel for things, or is the medical community, kind of on the forefront of things where they're saying we're going to take any tool that can help us?
The medical community is generally conservative for good reason, right? We don't take that many risks. That's how we were trained. It's very deliberate actions that are taken in order to have the best outcome. So just thinking that in mind, that's how physicians are trained for years, then enter the space where there's other things that are interacting. And I have to say that because I would say nobody has said, yes, I love the electronic medical record in the United States. That has really been the first encounter that physicians have had with technology. Mm-hmm. And because it's been such a sore point, physicians are definitely a little weary of other technologies, because what does that mean? In a lot of doctors' minds, does that mean a lot of work, a lot of administrative burden? I mean, these are all the issues that are currently a sore point because of the use of electronic medical records. It hasn't done anything other than to help with billing. It doesn't facilitate treatment, doesn't facilitate anything that's of value other than it's serving as a billing mechanism. So if you have that framework of, well, this was the technology that was forced upon me, I don't know what other things are looming that now are coming into play. And I would say beyond the electronic medical record, something that's specialty specific for me is the use of artificial intelligence, specifically CADI and CADX, so computer assisted diagnosis and computer assisted detection, in a very specific use case of colonoscopies, trying to find those polyps to prevent colon cancer. You know, the thought is everybody gets a screening colonoscopy at a certain age. I use my eyes, right, to go into your colon. For, people generally don't like this procedure, but understand that it has to be done in order to prevent colon cancer. But with my eyes, that's kind of being replaced by machine vision now with this technology, is to capture all those polyps that are in there that sometimes are missed depending on the view. The colon isn't straight. So depending on the view, they can be missed. So obviously going up in that percentage of capture prevents colon cancer down the line. I would say when it's very specific like that and doctors are able to use the technology and see the difference that it does make in their own numbers, then it's something that's easier to accept versus, like I said, the electronic medical record that really isn't serving anybody other than to use it as a billing mechanism. So I would say that's the contrasting view, is electronic medical record still a little bit, not so great. AI applications, I would say it's not bad. Physicians are willing to accept it as long as there is some patient outcome that's beneficial.
Mm-hmm. And Claire, does that hold true as well? I mean, at least the doctors and the medical professionals that you've dealt with over the course of your work, when are they? I mean, I don't know how the infrastructure is. I mean, I'm originally from New York, but are you getting good data? Is the data easily available? Are doctors willing to put in the work to digitize it there?
Well, so I'd say that yes, it has taken some work, but yes, we are moving into the fourth industrial revolution currently. And the fourth industrial revolution includes both AI and blockchain. So most of the industries, including the healthcare industry, specifically here in Kenya, is moving towards having that. So as you know, I work in Afya Record, and for Afya Record to work, what we're doing is we're bringing in hospitals, right? And when Afya Record is enabling them to manage their patients from Afya Record. And Afya Record is also being used by the patients themselves to log in their symptoms. So in essence, yes, doctors, hospitals, and even patients themselves are eager to use these medical records. And in terms of the AI that we're using, is currently we're working towards helping doctors who are using the Afya Record app to diagnose whatever patients are suffering from. Now, let's get this straight. Using AI, we're not in essence taking the power away from the doctor. We are just modeling exactly what the doctor is doing and helping the doctor. We're like, okay, the patient has been suffering from a fever, this, and this. They probably have this disease or malaria, or they have this disease. And from there, the doctor also has a list of diseases that they can be able to work with and now provide a proper diagnosis. So yeah.
And is Afya Record, is that one system? Is that one system standard amongst Kenya that all doctors, if they are using a digital system, they're using that record, or is it kind of a bunch of different record systems that you're trying to gather data from and put it into Afya Record?
Yeah, so Afya Record has one system of doing things. So immediately, or any hospital comes into the platform, they are provided with all these things already set in place. I think Alex has something to add on to that as well.
Well, I think that the answer, Yonah, is both. In other words, where there are legacy systems, the Afya Record is not designed to replace it, and there's no need to replace it. Mm-hmm. And that the data can be held and will be held off-chain, and the transactions that will happen will benefit from Afya Record's features that are no different than what we see and what the audience knows what medical records look like, with scheduling and telehealth and billing and all kinds of things. That's not the secret magic. The secret magic is really what Claire spoke about, and that is putting it in patients' hands, that it is a patient-owned electronic health record where they can get insights into what they have right now in real time, and they can port it. So this portability is important. So if I am sitting in Nairobi and I am going to Mombasa or leaving even the country, and there's, for example, a network of hospitals that are run by nuns in multiple countries, and I go to Kinshasa or Kigali, I can actually use this without the necessarily having a singular type of electronic health record. And the idea behind it really is to incentivize this transfer of knowledge. And the CEO of Afya Record, John Kamara, tells always the story that the impetus for him was that simply a good friend of him, a young friend, died from a simple disease because the doctor at the emergency room did not have the relevant information in the patient's hands. And that's really what it comes to solve. And what pertains to AI and what Samantha spoke about is really the evolution of what machine learning can and cannot do. So right now we're at that phase where we're moving out of the I would say analytics and big data, moving into predictive modeling, and that's what Claire mentioned, but at the end, hoping that this will also give us some prescriptive capabilities and to say, okay, in this situation, this is the best recommendation possible. Always bearing in mind that these things have their limitations, and so we have to know what they can and cannot do, and that the idea of opening the black box, the idea of creating a crowd intelligence that is not biased, that is diverse, that includes, multiple data sets is really what's exciting. And if we'll have time to mention a little bit federated learning, I think that the future really is the fact that this data will be in the hands of patients and patient-driven.
And it seems like a large component of that you're saying is patient self-reported symptoms and self-reported data. When it comes to medicine and health, how reliable is patient self-reported data?
If you're asking me, I'm a pain doctor, and obviously we always say that the easiest pain to treat is the pain of others. So I'm a big fan of first voice reports. I don't believe that pain is what people say it is, and I think that all these tell me from 0 to 10 how much pain you have is silly, because it assumes that it's linear. It assumes that your 0 and your 10 is my 0 and my 10, and it assumes that the meaningfulness of that pain can be decontextualized, as if my hand hurts the evening before I have to give a concert is the same thing that my hand hurts when I wake up in the morning. So I think that patient-reported outcomes, the subjective report comes from the subject, and therefore it is always true. It is always true. The thing is that we now have the ability and the technology, and I'm sure Samantha will talk about it, of all these technologies and of biometrics, or the third party or observable ways of how to contextualize the personal report. But we can't say that it's not important. I think asking someone, how are you, is way better than to look at someone and say, I'll tell you how you're doing.
And Samantha, when we're talking about data and machine learning, and trying to combine zeros and ones, and trying to take what Alex was saying, self-reported, subjective feelings, how do you digitize, or how do you get a computer or an AI to understand the context, to understand my hand hurts the night before a concert, to understand not just out of 0 to 10 how much pain I'm in, but the human factor there?
I just think when Alex was talking, I was thinking about medical school and how we're taught how to write a physician note. And Alex, you remember, right? Like the first thing that goes in your physician note is something called a chief complaint. And that is something that's specific to the patient, that they come in, like for me, nobody comes in and says, I need a colonoscopy, right? They'll say, I'm having issues going to the bathroom. That's exactly word for word that goes in the first part of a physician note. But then if you think about the other components of a physician note, and this is relevant to your question, it provides context. So after the chief complaint, it comes something called the history of present illness. And that's where it doesn't have to be a physician, but it's someone that's note-taking, deconstructs that chief complaint a little bit more, gives it time, it gives it severity, associated symptoms, like what else is happening, how long is it happening, does it happen only in this time or this time? And then after that, then you have all the objective findings. So that's almost thinking of like all the wearable data that we have. But in a specific medical setting, it's your vital signs. So do you have a temperature? Do you have high blood pressure? How was your physical exam? So all of that is needed to add depth to that beginning chief complaint, to that beginning patient-reported symptom. You need all of those data points. You can't just go simply by that first headline of the chief complaint. you need extra data points. And again, it's a mixture, right? It's subjective and objective to actually give something very rich in the end that is actionable, that does pertain to that person.
Now, we're talking about health here, and we mentioned, like you just said, this is something I learned in medical school. I mean, this is the ABCs there. It's a unique industry. It's a unique field. You're dealing with people, with human beings. You're dealing with their lives, their pain, how well they could function in this world. So clear to you as a data scientist, what unique challenges do you face as a data scientist in dealing with health specifically? I mean, as a data scientist, you could have dealt with finance or things that are much more zeros and ones that fit in very nicely into labeling. So what are the unique challenges that come from being a data scientist specifically in the health field?
I think the biggest challenge that is being faced is a lot of resistance. Resistance in that people are used to the old way of doing things, and this isn't, I think it's not necessarily AI only in healthcare, it's AI across multiple industries. People think AI is going to replace them and take away their jobs. When you mention an AI being able to provide a diagnosis, when we're talking about after record to most doctors, to them they get taken aback, thinking, oh, so this thing is going to take my job. So that's the biggest challenge. Another challenge is with regard to getting access to data. Now, for what we are trying to do is, in order to make an AI even capable of being able to provide any little diagnosis, you need a lot of data. Because you mentioned how AI is even able to understand basic symptoms. The cool thing about it is that it's automated, it's autonomous, and it's adaptive, meaning that it learns as it goes. So the more data that an AI system is fed, the more it will understand. And this also jumps into NLU, which is natural language understanding and natural language processing. The more data this machine is fed, the more it's able to understand what as a human you mean. So that's the other challenge. So I think those are the two main challenges with regard to healthcare.
And I want Yonah to take, because that's a really important point, that not only everybody knows that AI needs a lot of information or a lot of data that afterwards, by different techniques, be it deep learning or be it by back propagation and reinforcement learning, or being a combination of two, of deep reinforcement learning, it's that AI or machine learning, or these machines that we will work with, will help us learn about ourselves better. So when we talk about what's called GAN, generative adversary networks, where they can create deep fakes, or they just change a little bit, or everybody I'm sure heard about when Microsoft decided to apply a machine learning program to Twitter, and like they stopped it the next day because the Twitter feeds were so awful. It actually is not a bad thing, because it teaches us more about ourselves. It's like, wow, is that really how I sound in Twitter? So maybe I should modify myself. So it's almost like this human machine dyad is a mirror where we can look at ourselves and say, although we perceive that our thoughts are a certain way, or the way we present ourselves, or our thinking processes as such, when you actually analyze it in an objective way, the patterns are very different. So it'll be very interesting to see the behavioral aspects of how not only will AI help us interact between ourselves, but how will we interact with machines? How will we talk to robots, companion robots, and also, who knows, maybe a future profession will be a psychologist between AI machines, and how do they interact between themselves? So we're opening really a more rich world that we're going into that requires us to understand not only what these machines can or cannot do, but also introspect about ourselves.
Now, I'm going to direct this to you, Alex, and anyone else who wants to take it can follow up. Claire mentioned that these type of AI, I mean, any AI, machine learning needs a lot of data. And when you're talking about health data, people are they're a little protective. They want it to be private. They don't want the whole world to know that they are dealing with certain issues. And it is inherently a private thing, health data. So can you see a future where not only is one owning one's data, one's health data, because it's on the blockchain or whatever method or platform we do find, but they're actually able to monetize it by feeding their data into these models. If I'm a giant medical corporation, I want to buy or acquire data to feed into my model, into my system. Can you see a future where patients are able to actually, anonymously, obviously the data will be anonymous, but actually monetize their data by feeding it into these systems?
Well, you asked two questions here. One is the privacy, and the other one is the reward system. I'll leave privacy for Samantha, because that's the expertise of all these zero knowledge proofs that are privacy in-depth technologies, if you wish. But I'll just show you in the audience here. This is the way to do this. This is a card that's worth a couple of cents, that cannot be hacked, that on its chip has your access to your electronic health record or your passport or your DMV or your college grades and all that. And on it is loaded smart contracts that can define what are rewards. So if you go and get a vaccination, then you can be paid by a certain currency. If you actually wear a mask, if you distance, if you adhere to treatment. So the answer is yes, the technologies already are out there. And we can make this conversation a very technical one and start talking about homomorphic encryption and trusted execution environments and whatnot. But it's just like Claire said, the resistance is the human nature of understanding things. So I think that why these conversations with you are so important is that it demystifies the language and transforms it from something that is theoretical or esoteric to something that, wow, I can actually have that card and be paid for doing good stuff. And that it could be, if you wish, universal health income, instead of universal basic income, that where I'm getting allowance from whoever because I can't get my stuff together. This is universal health income that if I behave in a certain way, we will be rewarded. And it could be monetary, it could be non-monetary, it doesn't matter, but the technology exists. As for privacy, I'll let Dr. Nazareth talk about this, but there are technologies out there that can protect the issues that you mentioned.
Take it away, Dr. Nazareth.
Yeah, so privacy, both in hospital system, doctor offices, I'll speak to, and then just personal health data. So first you have to think about what's protecting everybody, right? What regulatory standards, rules. The current ones that are out globally, the big ones are GDPR, CCPA, and then HIPAA. CCPA and HIPAA being the United States regulations. Now, what even colleagues don't understand this, that HIPAA only protects the information that's held in a hospital system, a doctor's office, or an insurance company. Anything that's generated by the patient, let's say from an Apple Watch, an Oura Ring, any wearable, that's actually not covered under protections under HIPAA. So this is where that gets a little tricky. And for people who signed up for, to get genetic testing, they saw later on down the road that that data was sold to the highest bidder, right, to a pharmaceutical company. Now, I think people understand that, okay, the data has value, and obviously data altogether has value to somebody or something. And it's just a matter of being part of the conversation, right? Did I give consent to that later on down the road for it to be sold? no, I did not. Or perhaps I didn't read the terms and agreement with like, magnifying glass, and who reads those, right? When you're signing up for an app, anything else like that. So that part becomes, well, I wasn't part of that conversation in what happened to my data later on. And that will change with policies. That has to change with policies in order for everybody to get on board to say, okay, well, all of these other entities are not covered under, HIPAA, and this is very US centric. But once that occurs, then the user, the individual, the patient can participate to say, you have a right to my data. I have the right to be forgotten. I can sell that data, and I can kill basically my digital identity when I want. And so not until I really believe that it has to come from a policy standpoint in order to affect all of this change, because then everybody will have to kind of fall in line and move forward in terms of how that data is stored and eliminated and exchanged.
And is that something that's currently being discussed on a legislative level? The idea that even medical data from wearables, I mean, that's crazy that it's not protected.
Yeah, I mean, there's been so many headlines. 2 period tracking apps exchange data with Facebook. A lot of women were enraged because there was a lot of, you can imagine there's sensitive data and then there's ultra sensitive data, and ultra sensitive data was being exchanged. So there's that. And then on a bigger level, so going back to the hospital systems and enterprises, where there are, basically honeypots of data, of health data, while it is regulatory, protected by HIPAA, there are bad actors out there that breach and hack into those systems to sell the data on the black market. And just recently, there was actually a death associated with a data breach in Germany. So it's now impacting people's lives. The fact that this data is being stored in an area or, a centralized server that's hackable.
Mm-hmm. And this, I guess, goes to anyone who wants to answer. We're talking more and more about utilizing the data to help make better health decisions. Because at the end of the day, I mean, to keep us healthy and help us make better decisions, help the doctors make better decisions. But when it comes to being a physician and actually treating someone, we see that bedside manner helps. That this feeling of compassion is actually integral to the betterment of someone's health. It's not just the doctor telling me, making the correct diagnosis, but also treating in a compassionate way. So I guess anyone who wants to answer this, I could see this going both ways, and you could tell me which way you think is more likely. One, the models and predictive models becoming so advanced and so good that a doctor is no longer needed, but rather the model, the AI makes the diagnosis, and then there's a nurse or some sort of new job that's just the compassion giver. So that's one future I see. Or is it going to be continuing like it is today, where the doctors are going to continue to work alongside the models, because the models will never be perfect, and so the doctor at the end of the day will make the last decision and will be aided by these models?
I could answer that briefly. So Alex and Claire can chime in, but it's funny because it's always said that actually nursing is future-proofed because of that element of the human interaction, that they are saved from AI and physicians are not. And I am definitely not blind to the fact that AI will get better than humans and a human physician. It speaks to basically what I mentioned earlier, is that medical knowledge has been doubling every couple of months and it's just increasing. So how does one individual keep up with that and know all the data from everywhere at every time point with all the things that are happening? It's just simply not possible. And, before getting to that point, I think, with the algorithms the way they are, and in terms of incorporating into medical practice, I think for physicians to feel more comfortable with artificial narrow intelligence as it is now is to understand what how the algorithms came up with their percentage. So using that example that is currently, it's not actually approved in the US, but with the colonoscopies, with the CAT-X, with the diagnosis of the polyp, it says, is this, cancerous or is it benign? So, and that's obviously important, but it gives a percentage as well. From a doctor standpoint, okay, this is it's not make or break, like, oh my God, because with my own eyes, I can kind of tell as well. But something like that, I want to know how that machine came up with that percent. And they come up with 100%. It's not like 70%. It's like 100% certain that this is that. And now I'm left with, okay, I can leave it, right? Because the machine is telling me it's benign. There are huge legal implications to that. So I think that's really where physicians are being kind of caught in the middle is, well, what if a machine tells me 100% that it's benign, that I should not take this out? I need to know why that machine came up with that algorithm.
And Claire, are you able to quantify that at all? Are the models there? Are they already exceeding the abilities of the doctors when it comes to diagnosis? I'm sure it really varies depending on which field of medicine, but right now, as the predictive models and the diagnostic models stand, are they ready to surpass the ability of the doctors?
I would not say that they entirely have surpassed them. They are exhibiting very high percentages, as Samantha has mentioned. And I'd like to mention two things. So the whole thing with AI being able to diagnose, as I had mentioned earlier, the purpose is not to get rid of doctors. I like to call it the human-machine integration. No matter how excellent our AI engine is, we still need the compassion from the doctors and all you've said. So it's forever, it's always supposed to be working hand in hand. And then what Samantha said about doctors being able now to know how these machines are coming up with these percentages. So interesting fact is that actually AI and blockchain, they're coming in together to be able to every time that an AI engine comes up with new models or rectifies itself. Actually, right now, people are working on having the blockchain record all this information. So possibly in the future, thanks to the fusion of AI and blockchain, we'll be able to know how actually these models are coming up with these better predictions. So yeah.
And Yonah, I wanted to answer also that question of compassion, because I think it's really the most important question in this conversation, and I'm glad we're having it because I don't think we have it enough. I think first of all, like Claire said, it's a false dichotomy. We're not, it's not an and or thing, and I think it's all about solving problems, and these are culture and situation specific. So definitely, for example, in Japan, where it's an aging society with single children, companion robots serve a real role in the maintenance of the health and well-being of the Japanese people. I doubt that in Nairobi that would be an issue, simply because their families are larger, it is a storytelling culture, and machines have not developed the IQ, emotional intelligence, social intelligence to fill that role. I will say two things that I think are very important, and if anything that I would want the audience to remember are these two things. One is that technology doesn't do anything. Okay, it's what people do with technology. It's like a hammer. A hammer, you can crush everything, or it can sculpt the Michelangelo's David. So AI will be only as good as we design it and we utilize it. But the second thing, and that's why I was thinking a lot about, why are people so afraid of being replaced? Why are people so obsessed? Why is that, in every single AI movie, You know, these are the doomsday things that we talk about, moving, you know, from perception to understanding to awareness. And then that awareness will always be lethal and detrimental and apocalyptic. Is that, unfortunately, and this ties back to everything that we talked about, COVID and technology and what's going on right now. We live in a time that we love things and we use people. We love things and we use people. And what we need to do is go back and love people and just use things. And that's basically what this is all about. That when we talk about security and privacy and tracking and all this, doing it to stuff, to things, that's fine. Doing it to people, that's something else. So instead of loving things and using each other, how about we just go back and just use things and love each other? And that's why I always talk about this, not social distancing, but physical distancing and social solidarity.
Really wonderfully said, Alex. As always, it's both informative on a technical level to speak to you, as well as just wonderful human insights you have as well. That is all the time we have for the panel, but it's really an incredible conversation, and I really appreciate you each of you joining us. Dr. Alex Cahana, Dr. Samantha Nazareth, and Claire Matuka. Thank you, all three of you guys, for coming and joining and giving a little bit of your expertise to a lot of the people around the world who you know, might not be up to date or really be plugged in on these unique issues. So I thank you all, each of you, for taking the time. And for Reimagine 2020, I'm Yonah Hochhauser. Thank you for watching.